So I will start speaking on my topic. It's imaging and radiological interventions for backache. I mean, I'm doing CTs, ultrasound, and plain radiography, MRI. The backache is a very common presentation. We get a lot of patients with backache for imaging. So in the lecture, I would like to cover the available imaging modalities, limitations, advantages, disadvantages of each modality, and the appearance of imaging modalities in the common condition, and finally the basic radiological interventions in managing backache and diagnosing backache. So backache, one of the most common conditions we encounter in our day-to-day practice. The good thing is majority are self-limited and benign. The first step is to take a very good history, excluding all the red flag signs, which I will come in later. What are the red flag signs that will indicate there is something underlying other than the benign cause for a backache. And thorough physical examination. That is the first thing you have to do when a patient comes with backache. So those are the common causes for backache. I think it will be important for the medical students who are taking histories from the patients. The common causes are the mechanical causes. Out of that, muscle spasm or the strain are the most common cause and cause about 70% of patients with backache. And second, the degenerative changes that is mainly involved in the disc disease. And then the sacroiliitis, spondylolisthesis, spinal canal stenosis, and then facet joint osteoarthritis is also one of the common conditions that we don't diagnose very often. That is one of the common conditions that you can get backache. Non-mechanical causes like spinal tumors could be primary or metastatic disease, axial spondyloarthritis, spinal infection, very small percentage, but that is also one of the important causes that you have to exclude. And the extravertebral causes, there are a lot of causes in the intra-abdominal causes that can cause or give rise to backache, like abdominal visceral organs, cholecystitis, pancreatitis, vascular diseases such as aortic aneurysm, acute aortic syndrome, urological causes, pelvic causes also give rise to backache. So when to do imaging? Now, according to the guidelines of American College of Radiologists, appropriateness criteria for low back pain updated in 2021, according to that, you should not straight away go for imaging if a patient presented back pain. You have to at least 4 to 6 weeks we have to observe the patient unless the patient is having any red flag signs and conservative management. And after that, if the patient still having backache or associated with the neurological signs or red flag signs, then you can do imaging. So what are the red flag signs? That is that means when these symptoms or signs are there, that means there's something underlying which is causing backache. This is not just a simple backache. Like cancer or infection, one of the underlying cause which can give rise to backache. Like from the history, you can get whether there's a history of malignancy, unexplained weight loss, whether the patient is on immunosuppression, urinary infection, intravenous drug use, or patient is on a long-term steroid treatment, and back pain is not improving with conservative management. So that is one of the indication that we have to go for imaging. And there's another one, spinal fractures. That is also can give rise to backache. So then you can take the history, whether there's any history of trauma, recent trauma, or prolonged use of steroids that will weaken the bone, or minor fall, or some kind of a lifting heavy weight, known patient, elderly patient or known patient with osteoporosis. So what are the diagnostic imaging modalities we are commonly used? We use MRI, such as X-ray, MRI, CT. We are commonly used. Sometimes we use isotope bone scan, but that is not to diagnose backache. So more advanced imaging like PET scans are there, but I'm not going to discuss much about because time is limited. So now there are, lot of imaging modalities are there. So they will look at the spinal abnormalities in different angles. For example, MRI will give rise to, MRI will give you a lot of information about the soft tissues in the spinal canal, spinal cord, cauda equina, and the nerve roots. Like when the CT will give more information about the bone abnormalities as well as X-rays. CT also provides soft tissue details, even though it is inferior to MRI. So the MRI is so sensitive, sometimes it gives a lot of, when we are interpreting, we are reporting, we say a lot of abnormalities, but they are not, may not be causing the backache, may not be related to backache. So it is very important to interpret with great caution. So when you decide which investigation I am going to do, so you have to that depends on the patient's presentation. If the patient presents after a trauma, we are not going for MRI straight away. Either we do CT or X-ray. If the patient is having neurological symptoms with spinal injury, we might go for a MRI. Like patient's presentation is important. And the presence of contraindication. Sometimes we want to do MRI, but patient is having contraindicated for MRI. So some problems having that patient can't undergo MRI. So then we have to use another modality to image the patient. And the availability, again, MRI, we know it's a very limited resource, not freely available. Sometimes we have to go for a suboptimal imaging even though we want MRI. Relative cost of the test. Again, you have to think how costly the test is before you are requesting the investigation. And especially it's important and expected impact of the result on the management. If a patient is very elderly patient, you are definitely not going to do any surgery. So no point of going for a very expensive, very high-end imaging investigation where even though you get a positive result, you are not going to do anything. So it's very important to find out whether you are going, depending on the management, whether you are going to do anything after you are getting the report. So plain radiograph. So most commonly ordered spinal imaging. We usually, it is helpful to evaluate the bony abnormalities like fractures, degenerative changes, joint infection, inflammation, you can assess. Usually we order AP and lateral, that is good enough, it will give a lot of information. Sometimes we go for oblique images, but not very often. One thing is other imaging modalities are there to assess. Other thing, it is radiation doses. Plain radiography. What are the things that we can see in the plain radiography? Alignment of the spine and whether there is any gross deformity. When you look at the X-ray, first you have to see whether alignment is correct, whether there are any gross deformity like scoliosis, kyphosis, or the deformities are there in the X-ray. And then look for the bone density and the architecture. You look whether the osteoporotic or whether there is some other abnormality in the X-ray in the architecture. Spondylolisthesis and lysis. Altered lordosis, whether excessive lordosis or reduced lordosis. The lordosis absent or reduced lordosis indirectly indicate that the muscle spasms are there in the lumbar spine. And whether there are any congenital anomalies in the spine, scoliosis, spina bifida, sacral agenesis, etc. Degenerative changes. We can see disc space narrowing, marginal osteophytes, bone sclerosis near discs, and the signs of spinal infection. Disc space narrowing with bone end plate irregularities, sclerosis, vertebral body destruction, paravertebral soft tissue masses, calcification, those things will direct that there may be underlying infection. And even bone tumors we can diagnose or identify, actually speaking, identify in the plain radiography. So this is the normal lordosis, normal lumbar curvature, you call it lordosis. That is what you see in a normal lumbar sacral X-ray. And this X-ray, I think you can see the difference. There is a straightening of the spine. The spine is straight. Lordosis is no more there. So that is a straight spine due to the muscle spasm. Scoliosis, that is the lateral curvature of the spine. This could be congenital or acquired scoliosis. Often the cause of the scoliosis is not known. This is a degenerative scoliosis. It happens later in the life due to the degenerative changes in the lumbar vertebrae. You can see osteophyte formation, then a narrowing of the disc spaces, reduced vertebral body height. Those causes lateral curvature of the spine. What is spondylolysis? That is, I think this is famous squatty dog appearance. I think medical students you all know during the lectures we have taught you. This is the squatty dog appearance in the oblique weave. So that is the broken squatty dog collar. That is the pars interarticularis fracture that they can get during degenerative diseases. The spondylolisthesis is the subluxation or migration of the vertebral body relative to the adjacent vertebrae. So that can, depending on their degree of migration, if it is involving less than 25% of the end plates, we call it a grade 1. If it is 25 to 50, it is grade 2. And if it is more than 75, it is grade 4. So when it is migrating, it may be associated with the pars fractures. We call it spondylolisthesis and lysis, both are there. So during this migration, it can cause narrowing of the spinal foramina. Narrowing of the spinal foramina. So that can cause compression of the nerve roots, or sometimes narrowing of the spinal canal. That can cause nerve root compression or compression of the coda equina. That can give rise to backache. So this is a young patient, actually female patient, presented with backache. All the imaging investigations were done. Even the MRI was done and it was negative. Nothing, I mean no nerve root compression or negative. Can you identify any abnormality here? X-ray. So that is the abnormality, spina bifida. So this is actually congenital malformation, defects in the closure of the vertebral arch. Sometimes they can present with backache. Actually that girl was having only that was the positive sign. All the other investigations were negative. So the degenerative changes in the spine. Again, you can see the vertebral, this is multi-level involvement with vertebral body heights are maintained. And multi-level degenerative changes are there. Here you can see the body height is maintained and reduced disc height. Usual normal disc height is this, and if you see the one below, it's reduced disc height, and then the osteophytes formation, and then the facet joint sclerosis, facet joint arthropathy. These are some of the common degenerative changes that you can see in the plain radiograph. This is a patient with degenerative changes in the spine. MRI, CT and the X-ray. The image C is the X-ray. There you can see L5S1. There is a narrowing of the disc face and the sclerosis of the end plates. In the CT, in addition to that, you can see some low density areas. Those are air. You call it a vacuum phenomena. That is also another appearance in the degenerated disc. And the MRI, you can see, if you see the other intervertebral disc, these are normal signals. Center is high, nucleus pulposus, and the periphery is low signal. Here, the whole disc is low signal, reduced height with posterior bulging. So this is a patient with backache, known patient with bladder cancer. So this is a patient with a red flag because the patient is history of a cancer. So immediately, I mean after the presentation of backache, X-ray was taken. Any abnormality can you detect? This pedicle is distracted. Okay. So L1, right pedicle is distraction. So known patient with bladder cancer, what is the most common cause? We have to always think of a metastatic deposits. We call it a winking owl sign. If you see one eye owl, one eye is closed, I don't know whether you can see clearly. So one of the causes is the metastasis. It could be some other causes as well. When you can't see a pedicle, maybe some absent pedicle could be, maybe after radiation therapy, maybe obscured by the bubble gas or some other artifact. But still you have to exclude possible metastatic disease or malignancy. So this is a patient who has admitted with backache, high ESR, fever. The X-ray appearance was like that. L4, L5 level, there is a irregular end plate with narrow disc space and sclerosis. And with further imaging and other investigation confirmed it was spinal tip. What are the limitations of lumbar radiography? The main limitation is the radiation. Some abnormalities like facet joint, mild scoliosis are incidental finding and may not be related to the backache. And you can't comment on the disc. Only the disc height we can see, we can't visualize the intervertebral disc. And the nerve root also we can't see. And poor visualization of the soft tissues, and cannot show the details of the spinal canal. Actually, this is a 2D imaging. If you want to see the spinal canal, you have to take a cross-sectional image. The next imaging modality is CT. Actually, CT has a limited role in assessing low back pain, but certain conditions that indicate CT is needed. Like when you do the MRI, if you want to see the bony details, especially the cortical bones, we have to go for a CT, because MRI is not very good in assessing the bony details. So some patients who can't undergo MRI, when they have contraindication, or some patients claustrophobic, or some patients can't stay in the MRI for a long time as patient is not stable. Those kind of patients can undergo CT. And especially the trauma patients, CT is the first imaging modality. So advantage, it's excellent demonstration of bony anatomy and the bony changes. And it is relatively more available than the MRI and much cheaper compared to MRI. So as it is, you can do it very quickly. The patient motions or uncooperative patients, that won't affect the image quality. So the patients who have metallic foreign bodies or pellets or fixation dividers can safely undergo CT. So when you compare to the radiation dose, the X-ray, the CT radiation dose is much higher. So that is one of the limitation. And again, the intraspinal, we can see the spinal canal, but spinal cord or intraspinal neural content, we can't see it. So artifacts from metallic fixation patients can undergo CT, but there will be some artifacts. You can see some artifacts. So even though we do CT, the image quality is not so good. So you can see very bright artifact here that cause obscuration of the surrounding tissues. Even though they can go, that is a limitation. So the diagnostic value show very well the bone abnormalities, osteolytic, sclerotic lesions, abnormal configurations, deformities, fractures very well. And if you want to locate a metallic foreign body, you can exactly locate the foreign body. Bone erosion secondary to inflammation, infection or tumor can be assessed. Features of spinal degeneration, calcifications, you can assess. So this is the lumbar spine, axial and sagittal images of soft tissue window, not the bone window. So now, as we don't have MRIs, some patients are waiting for a long time in the waiting list to get it done MRI. But certain information we can get by doing CTs as well, especially the exiting nerve roots. I think you can see here, that is exiting nerve root, compressions and the other degenerative changes you can assess in the CT. So not only in our country, even recently I met one of my friends, she's working in Australia. Even there, they do a large number of CT for this backache, even though the MRI is available. So still they are practicing, and there is a lot of information you can get by doing CTs. Another thing, the now CT machines are, very well technically improved, and they give a lot of soft tissue as well as osseous information of the images. So this is the CT spine. You can see there's an abnormality in L1. What is the abnormality? Anterior height of the vertebral body is reduced compared to posterior height, and the vertebral AP diameter is maintained. That is a simple wedge fracture, wedge compression fracture in the L1. And what is this? There is some destructive changes noted in two vertebrae. You can't say exactly what is number of, because cervical or this lumbar region is not involved, but there are two vertebral bodies are involved with sclerotic changes, irregular end plates with narrow disc space. So axial image, you can see there is associated paravertebral soft tissue thickening as well. So in the coronal, you can again see the destruction and the paravertebrae. This is the spondylodiscitis that we can diagnose by taking a sample from here. That can be done with the aid of the CT. CT guided biopsy will confirm what is the diagnosis is. So this is the patient presented after RTA. Now again you can see there are some abnormality in this vertebrae. What happened? There is some fracture, reduced vertical height, and not like the previous one, wedge fracture. Here, this one, posterior vertebral body is bulging into the spinal canal. So there is a narrowing of the spinal canal. We don't know about the neural contents. So this is the AP. You can again see the fractured segments are bulging away from the vertebral margin. Again, the axial, this is axial image. This kind of patient, if the neurological symptoms present, should undergo MRI. This is the MRI of the patient. You can see this is the STIR. STIR is very sensitive imaging sequences to assess the bone marrow edema. So because of the fracture, you can see the edematous bone marrow. Usually in the STIR, fat is suppressed. This is normal vertebrae, suppressed fat. That is why you see it as darker. But here, due to edema, it is more brighter. And this is T1. The edema appears as darker area. And there is no significant compression to the quadrant equina except the impingement of the thecal sac. So this is the myelogram. Now of course we are not practicing very much, but sometimes myelogram we have to do because some patients are contraindicated to undergo MRI, and CT information also limited. These kind of patients we are doing myelogram, either fluoroscopic guided or CT. Here you can see there is a compression of the thecal sac because of the disc prolapse. You don't see the continuation of the contrast column. This is a CT myelogram. This is AP. You can see the outline of the spinal cord and the nerve roots. So it has been doing for a long time. Then now we are not doing as MRI is available, but still we are practicing in indicated patients. MRI is considered as the imaging modality of choice because it demonstrates very good soft tissue resolution and good and assess the regional pathologies. The main advantage, there is no radiation and it is non-invasive procedure, excellent imaging quality. It is currently the most accurate modality in demonstrating the spinal cords and the nerve roots. But there are some limitations. If there is an uncooperative patient or patient can't keep in the MRI room for a long time, the image quality is affected by patient motions. And then long examination time. Some patients can't stay in the at least 15 to 30 minutes it takes for a MRI spine. Sometimes bony details you can't, not very accurate bony details you can gain from the MRI. And sometimes clinical MRI mismatch. Sometimes patients are having backache, but the MRI is so accurate or so sensitive, sometimes they find pathologies which are not related to the backache. So we have to interpret the MRI findings and the clinical findings more cautiously. The contraindications are the pacemakers, metallic objects, claustrophobia, etc. We usually don't give gadolinium during the pregnancy, even though we are doing pregnant patients. The diagnostic value, they detect common pathologies which give rise to low backache, like the disc herniation, nerve root compression, lumbar and canal stenosis and degeneration, evaluation of the spinal canal, any masses within the spinal canal or outside the spinal canal, within the spinal cord, we can detect the exact location of the masses. And this congenital spinal malformations like scoliosis, spina bifida, meningomyelocele, dermoid, tethered cord, low-lying cord, all these things we can diagnose with MRI. So this is the normal MRI sequences what we do, as there are some medical students in the audience, I have just included. So this is the T2 weighted. In our sequence, we usually include T2 weighted sagittal, T1 weighted, and stir. The difference between the stir and the T2 is, in the stir, the fatty tissues will be suppressed or dark. So compared to T2, you can see bone marrow is dark in the stir. And this is the subcutaneous fat, which is again dark in the stir. The fat is bright in the T1, and the CSF is low intensity in the T1. It is high in T2 and stir. So again, this is the coronal T2 weighted images that is also included in the routine sequence. And this is the axial section, the lumbar canal. This is the intervertebral disc. Center is high signal and the periphery is low signal in the T2 weighted images. You can see the thecal sac with nerve roots. Here again you can see small dots like. And this is the where this foramina, where the nerve root is exiting. You can see the foramina like this. And this is dark area here is the ligamentum flavor. And there's a bright area over here. It is the epidural fat. So this is the intervertebral disc pathologies in the MRI. Now you can see this is the normal disc. And L4-5 and L5-S1 intervertebral discs are abnormal. That is the altered signal intensities you can see. So this is L4-L5 is bulging of the intervertebral disc. You can see this little bulging over here. But the nucleus pulposus is within the intervertebral disc. Here the nucleus pulposus is herniating through a tear in the annulus fibrosus. So this is the herniated intervertebral disc. Depending on the disc where it is protruding, you can get symptoms. Now this is, if it is central zone, it's protruding centrally, you can get the compression of the thecal sac and the coda equina syndrome. Like here, if it is laterally, in the lateral zones, foramen and far lateral, the compression will give rise to nerve root compression symptoms. So this is a lumbar spine, stir and T2 weighted sequences, sagittal and T2 weighted axial sequences of patient with degenerative changes. You can see all this lumbar intervertebral disc height is reduced and darker in color and bulging anteriorly and posteriorly. You can see like a zigzag pattern like in the thecal sac, that is impinging the thecal sac. If you take the axial section from one of these levels, that is what you will see. See what you can see here. So this is the bulging disc causing compression of the thecal sac. So but nerve roots are not much compressed, there is an impingement. And here this is the narrowing of the lateral edges, that where the nerve root can get compressed or impinged. And this is the facet joint, that is a normal facet joint. You can see nice white line, that is the small amount of fluid, and the smooth regular facet joint articular surfaces. Here you can see those are little thicker, that is the sclerosis of the facet joint, and this nice white line is not there. So that is facet joint arthritis. And this is the ligamentum flavor, that is thickened, that can cause narrowing of the spinal canal and lateral recesses and give rise to neurological symptoms. So this is a patient with spondylodiscitis. You can see there is a altered signal intensities in the L4, L5 discs. You can see this T1, there is a loss of fatty marrow here and irregular outline. Here you can see T2 again. There is some disc is edematous and bulging either side. When you give contrast, you can see enhancement of the contrast peripherally of the disc as well as around the soft tissues. Here axial you can see paravertebral soft tissues also inflamed. That is why you can see the inflammation. If you see there is a non-enhancing area with the peripheral enhancing area, that means that is an abscess. Here there is a soft tissue inflammatory changes are there. And this is the spinal tumor that you can identify, contrast enhancing lesion which is causing impingement of the spinal cord. That is a schwannoma. And this is another lesion that you can get in the spinal canal, that is in the T2 intermediate signal lesion, in T1 isointensive spinal cord. Post contrast shows avid enhancement with tiny, what you call, these are the dural tail. This is the dural tail sign. This is the spinal meningioma. In the axial section, you can see that spinal cord is compressed by this mass. This is the spinal meningioma. And this is, there are multiple abnormalities involving multiple vertebrae. You can see this is the lower thoracic, lumbar and the sacral segments as well. This is T2, T1. And this is the appearance of multiple spinal metastases. And again you can see multiple level involving low signal intensity lesions. Here you can see this is the vertebral metastasis. If you can see here, within the spinal canal also there are soft tissue density areas. Those are epidural deposits form a malignancy. This patient, this is CT. T1 and T2 weighted images of the spine. CT you can see lot of bony details. The vertebral body heights are reduced, AP diameter is increased. There are multiple lytic lesions and there are some destruction of the posterior margins of the vertebral bodies. In the MRI again you can see reduced height with multiple lesions, altered bone marrow signal intensity. So this is a patient with multiple myeloma. So this patient about 3 weeks ago referred to me with a 53-year-old female with backache. When I was going through the MRI, couldn't see anything much significant which is causing backache. The MRI was lumbar spine was normal like. So this is the one in the axial what I have found. This patient was having a large renal mass. That was the cause for the backache, and after that we have done a CT, it confirmed large renal cell carcinoma. So this is the coroner. So this is very important. We have to see not only the spine, adjacent other structures as well. So this is the patient. So that is not the cause for the abdomen backache is not the nerve root or the spinal problem. CT is a superior in assessing the cortical bones than MRI when you compare to MRI. And if the bony details is critical, like if it is in trauma patients, you should do a CT, not a MRI. Other thing is the facet joint problems, again CT is more sensitive. So both CT and MRI is useful in evaluating vertebral compression fractures. If you are suspected a fracture and do X-ray, and X-ray is negative, but it's the next imaging. You have to think whether to do a CT or MRI. So then you have to look for the patient is having any neurological symptoms. If the patient is having neurological symptoms, MRI is better than the CT, but still we can do the CT and assess whether there are any changes and then go for MRI, as we don't have freely available MRI. But ideally, if the neurological symptoms are there, so we can go for a MRI. So bone scan. Like we don't do bone scan for backache, but sometimes if you see some abnormality, if you want to confirm what it is or suspected stress fracture, occult fractures, infections, then we can go for a bone scan. And this, if you want to see whether it's acute or heel fracture, again bone scan can be done. It is usually sensitive or hot until 9 months, 6 to 9 months after the fracture. So it has a limited role in diagnosing backache. As MRI is more freely available, not freely, MRI is more accurate. Now we are, even occult fractures, we are doing MRIs now. Technetium bone scan very sensitive for stress fractures but are non-specific. A normal bone scan can exclude the stress fractures. And it usually positive for up to 6 to 9 months when there's a fracture. So the next part is the spinal intervention procedures for backache. So we do spinal interventions to diagnose as well as manage the lower backache. So sometimes treat non-operative back pain. So this is for the diagnosis. When there is a vertebral body lesion or paravertebral masses, we can do the CT or ultrasound guided biopsy and come to a diagnosis, and that will help to manage the patient. This patient has a paravertebral, that is psoas abscess. This is a MRI. So this kind of thing we can diagnostic as therapeutic. We can take the samples for diagnosis, and then we can drain, or either we can place a tube to slow drainage and treat or manage the patient. So the pain management, that is very important, and now it's becoming very popular. I think it's available in Kandy Hospital as well as Peradeniya. So the joint, sacroiliac joint, facet joint injections, spinal epidural injections are practicing. So what are the general contraindications? There are few contraindications. Active sepsis around the area that we are accessing, or known allergy to local anesthetic, steroid, contrast agents. During pregnancy, we usually don't attempt. And when there are bleeding tendencies, there is a risk of bleeding. Again, anticoagulation, again increase the risk of bleeding. And we don't repeat injection, maximum 3 to 4 per year, not more frequently than that. And if we are waiting for a surgery, again, the steroid injection will increase the risk of getting infection. So if there's upcoming surgery, we don't attempt steroid injections. The complications are very rare, but there are few, like common complications, infection, septic arthritis, discitis, osteomyelitis. Those are some of the very rare but complications. That allergic anaphylactic reactions, local reactions to steroid injection, and bleeding. Facet joint injection. Facet joint is, it's a poorly diagnosed condition, I think. Some patients, they come and say diffuse pain. It is not related to actually one nerve root, or you can't isolate where it is. So that kind of patient we can give facet joint injection. They come usually, what happens, there's a facet joint, there's arthritis and inflammation that can cause irritations of the nerves around the facet that can give rise to diffuse pain. So we can give a little bit of anesthetic drug and see whether the patient is responding to pain. If it is so, then we know the pain is due to that, and then we can inject the steroid. And another indication facet joint injection is the chronic lower back pain. And whether sometimes lower back pain with normal imaging findings, with or without sciatica, and post-laminectomy syndrome. These are some of the indications for facet joints. So you can do either CT or fluoroscopic guidance. CT is much easier. That is where the facet joint is. So with the CT guidance, you can access the facet joint and inject little bit of contrast and make sure that you are inside the facet joint, and then you inject the steroid and the analgesics. Here you can see little bit of contrast was given, and you can see it is within, the contrast has not gone out of the facet joint. That means it is within the facet joint, and it is little bit of bulging of the joint capsule. So both joints you can give injections at the same go. Sacroiliac joint, again, if there's a problem, you can give, pain is there, again you can give injections, again diagnostic and therapeutic. You can give little bit of anesthetic and see whether the pain is relieved, or if pain is relieved, then we can give a therapeutic dose. Usually we approach posteriorly under fluoroscopy or CT guidance. Now this is prone position. This is the marking grid. We do a plain one with the grid to guide the needle. So we take a direct access like that, most shortest distance, and then here now we have access like that and given the injection, and before that given little bit of contrast, make sure we are in the joint and like that. Usually drugs we used in the steroids, triamcinolone, depomedrone, dexamethasone with the long acting anesthetic like bupivacaine. That is for joint, SI joint and the facet joint. So spinal epidural injection is also used for the pain management. The goals of epidural steroid injection to control the pain by reducing inflammation around the nerve roots. So that will improve the mobility of the patient, and that will help the patient to continue with physiotherapy and other rehabilitation programs. So when you introduce a steroid medication, what happens? That is because of the anti-inflammatory effects directly into the painful area, that will provide acute and significant pain relief. So usually we use non-particulate steroid like dexamethasone here, because there is a risk of getting spinal arteries thrombosed and embolized, and then there will be some spinal cord infarction. That is why non-particulate steroid we used in the epidural injections with the long-acting analgesics like bupivacaine. There are 3 routes: transforaminal, intralaminar and the caudal route. So that can be again done under fluoroscopy or CT. The most effective is a transforaminal route, because you can precisely give around the nerve sheath steroid solution. Then interlaminar route less precise than the transforaminal, and the caudal route again only small amount of, again that will cause the diffuse pain relief, because you are not reaching the specific nerve root. So this is the transforaminal access. So that is the more effective way of giving epidural pain relief. So this is the translaminar. Patient is prone position, in between the lamina, accessing the epidural space and giving the injection. So finally, that what I want to emphasize is, in a patient with non-specific acute backache without red flag signs, you can conservatively manage up to 4 to 6 weeks and see. If the patient is not improving, or any other significant clinical history like clinical significant history indicate that red flag signs are there, then you can either do plain radiography, MRI, CT, depending on the patient's condition and the situation. Any questions?
Any questions from the audience?
Questions on the chat?
Check.
Nothing.
These days there are a lot of CT scans, so you mentioned that radiation is a problem.
Yes.
Should
Yeah.
we start documenting the amount of radiation received in each study, because different clinicians are asking for the
You are meaning each patient, and you have to have some kind of a dose record, how much dose he has, and that's a good idea. You can, small book or something you can give, because in the CT it says how much dose is, I don't know, that is how much the patient is getting, but delivery dose is there in the CT.